So for those of you who don't know me, I'm Paari Dominic. I'm one of the electrophysiologists here at LSU. So we're going to talk about arrhythmias in vascular heart disease. This was a talk that I gave at the Arrhythmias Symposium last year, and last month, actually, I was on the floor, and we had a case that we had a nice debate on what kind of anticoagulation to use. So I thought this would not be a bad idea to give it to the residents as well. We're going to start off with a case that I just recently saw in the hospital. Here is a 52-year-old lady with history of a subaortic stenosis. She's had multiple surgical procedures for that subaortic stenosis when she was really young. And finally, she had to have an aortic valve replacement done. She also had a ventricular septal defect that was repaired when she was 18 months of age. And during all these surgeries, somehow she also either ended up having a complication or a de novo mitral valve problem as well. And so she had a mitral valve replacement done a year after she got the AVR done. So she was referred to me for consideration for an AFib ablation because she was very symptomatic when she had these paroxysmal AFib. She had palpitations, dizziness, and lightheadedness. She was dyspneic on exertion, especially during the times that she had these AFib episodes. And in general, she was more fatigued in the last 2 to 3 years since she got diagnosed with AFib compared to all the years prior to the AFib diagnosis. So her last surgery was, I think, in her 20s, and now she was in her 40s. So for 20 years, she did really well until she developed the AFib. And so she was, very clearly symptomatic from the AFib. So this was diagnosed by an outside cardiologist who had initially put the patient on an antiarrhythmic medication, which is dofetilide. Sorry for using a brand name here, Ticasin. And you guys have, if you worked on the cardiology floor, I've started this medicine in some of our patients, so you know about this medicine. So she was already on dofetilide, which is actually one of the potent antiarrhythmic agents that we have, and she was still having bursts of AFib, and she was extremely symptomatic from that. So here is a more detailed surgical history. She had a VSD repair done in 1977, a subaortic stenosis repair done in 81, and then again in 91. And she finally had a mitral valve replacement done with a mechanical mitral valve in 1996. And she had a mechanical mitral valve done the year after that in 97. She does not smoke, drink, or use any recreational drugs, and she works as a news anchor in one of the TV channels in Alexandria. So here's a question. So for anticoagulation for AFib, and I'm going to actually see hands go up here. How many of you think that she needs to be on Coumadin INR 2 to 3? So nobody thinks she should be on, one thinks that she should be on Coumadin INR 2 to 3 for AFib, right? Okay. How many of you think she should be on Coumadin INR 2.5 to 3.5? Okay, quite a bit, about 15 of you guys. Eliquis, 50 milligrams POBID? None? Okay. She does not need anticoagulation because her CHAS2 VAS score is 0. Her CHAS2 VAS score is 0, right? She has no hypertension, no heart failure, no diabetes. She's never had a stent put in. She's never had a vascular disease. So her CHAS2 VAS score is basically 0. So how many of you think she does not need anticoagulation for AFib because her CHAS2 VAS score is 0? Okay. None. And aspirin and clopidogrel? Anyone for aspirin and clopidogrel? All right. So basically most of you are split between the two, and the others did not raise your hands for any of these, which I'm guessing is a sign that you either don't know the topic. All right. So then following up with the next question, she was initially sent to me for rhythm control strategy. She's very symptomatic from the AFib. So what is the next best step in the management of this patient with all these symptoms? Number one, continue Ticasin. How many of you think we should continue the antiarrhythmic agent that she's currently on with having multiple episodes of breakthrough AFib? Okay, nobody. Stop Ticasin and start amiodarone. Why not? Huh? Same class, number one. But usually amiodarone and Anticoagulation, even though they are in the same class, they work a little differently. And sometimes amiodarone does hold people in sinus rhythm when Anticoagulation doesn't, and Anticoagulation holds people in sinus rhythm when amiodarone doesn't. So it's not really that is the reason. But she's young. She's only 40. How long are you going to keep her on amiodarone, right? So the longer you keep somebody on amiodarone, the more side effects of amiodarone you're going to see. And then stop Anticoagulation and pursue AV junction ablation and a pacemaker. How many of you are up for that? All right, 2, 4, 5, 6, 7, 8. So would you do this as the next step for any patient that comes in with AFib and symptoms? What would you go for as the next therapy? Ablation. But you don't want to do this in this patient because? All right, good. So you do at least have a reasoning for that, and so then or refer to a center that does complex ablation. So that we're going to talk about all these things in a second. So today my goal was to basically talk about valvular atrial fibrillation, but I wanted to also touch upon another kind of arrhythmia that you usually see with valvular heart disease, which are heart blocks requiring pacemakers. So we're going to talk about the definition of valvular atrial fibrillation, what you do for anticoagulation, what do you do for rhythm control strategies, and how effective is ablation. And then in post-valve replacement surgeries, patients who already have a valve problem who go for a valve replacement surgery, what is the incidence of heart block during these valve surgeries? And what is this incidence, how does the incidence change in patients who have a transcatheter aortic valve replacement or mitral valve surgery instead of open surgery? And then how do you manage these patients? What is the prognosis of these patients? So basically, we're just going to talk about valves and AFib, valves and heart blocks, okay? All right. So first going on to valvular atrial fibrillation, there is about a 2 to 3-fold increase in the incidence of atrial fibrillation in patients who have valvular heart disease, both in men and women. So why is that? Because valvular heart disease causes increased left atrial pressure and it alters the wall stress on the left atrium that eventually causes left atrial myopathy. And the left atrial myopathy will then cause fibrosis, scarring of the left atrium that all sets up the substrate for having atrial fibrillation. Therefore, you have increased susceptibility to atrial fibrillation. So before I introduce you to the study, I just want to ask you, how many of you think you know the definition of valvular atrial fibrillation? Raise your hands. 1. Okay, at least you guys are honest. So, this was actually a study that was done in both internal medicine doctors as well as cardiologists. There were about 270 cardiologists and 240 internists. They gave them a bunch of questions that basically talked about whether the patient had a rheumatic valvular disease or non-rheumatic valvular disease. They said whether it was a mitral valve or an aortic valve, whether it was a prosthetic valve, a mechanical valve, or a bioprosthetic valve, and then how severe was the heart disease, how severe was the mitral stenosis or mitral regurgitation. So based on these, then they asked them a bunch of questions to kind of get their opinion of whether this was a valvular atrial fibrillation or non-valvular atrial fibrillation. So how many of you here think that lone atrial stenosis, lone severe aortic stenosis, not atrial stenosis, aortic stenosis is, and somebody who has AFib, is valvular AFib. So somebody has severe aortic stenosis and they have atrial fibrillation. You think this patient has valvular AFib? No, okay. How about severe mitral stenosis and atrial fibrillation? All mitral stenosis or just rheumatic mitral stenosis? Okay, rheumatic mitral stenosis, okay, but there is almost no other cause for mitral stenosis these days other than rheumatic valvular heart disease, but just to keep that in the back of your mind. How many of you think severe MR and AF is valvular AFib? Okay, who else? You have another answer? Okay, it was before, now it's not. Okay, I'm going to show you that data as well. And so let's go over the actual definitions for atrial fibrillation. So, by the way, 1/3 of people who were asked in this survey thought that lone atrial aortic stenosis and AFib was valvular AFib. 1/3 of them thought that severe MR and AFib was valvular AFib. And then a lot of others also thought that the severity of mitral stenosis did not matter when it comes to AFib. Do you think it matters or it doesn't matter? Okay, so mild mitral stenosis and AFib does not matter. You don't call that valvular AFib. Only moderate and severe mitral stenosis, you call that valvular AFib. So it does matter. The severity of the mitral stenosis does matter. So even though most of these guys who got it wrong were internists, if you look at the people who thought, the internists who thought that the definitions of valvular AFib was clear was much higher than cardiologists. So internists thought, oh, the valvular AFib definition is super clear. And they made all these mistakes while cardiologists thought that, many of them thought that it wasn't clear. And it's still not clear. Actually, I'm going to show you some data that it's still not clear what valvular AFib is. Okay, so here is the kind of like the evolution of the definition of valvular AFib. So in 2001, ACC-AHA said absence of rheumatic mitral valve disease and did not say whether stenosis or regurgitation, noted, or a bioprosthetic heart valve was non-valvular AFib. So remember, AACC and AHA does not actually define what is valvular AFib. It just defines what is non-valvular AFib and then lets you, decide which is valvular AFib. So it says that absence of rheumatic mitral valve disease and does not say mitral stenosis or regurgitation. In 2006, it did say the exact same thing, but also added absence of mitral valve repair to it. Okay? So here, if you had severe MR and AFib, you have to think that it is, it is a valvular AFib. But in 2014, they specifically said absence of rheumatic mitral stenosis, a mechanical bioprosthetic heart valve, and or mitral valve repair. Okay, so this is the current definition of non-valvular AFib. Anything that does not fit into this definition is valvular AFib. Got it? Questions? Okay. So moving on, what is the need for figuring out whether it's a valvular AFib or a non-valvular AFib? What is the most important reason we try to tease this out? Anticoagulation is the only reason, right? There is no other reason for us to tease this valvular versus non-valvular AFib. It's just anticoagulation. So the NOACs, the novel anticoagulants, are contraindicated in patients who have valvular AFib. The only anticoagulation you can use is Coumadin. So I wanted to go back and see if the actual studies that were used, the studies that were done using NOACs had any of the valvular AFib patients. So all the big trials, Engage is Edoxaban, Aristotle is Apixaban, and Rocket AF is Xarelto. Rely is dabigatran. Dabigatran did have some mechanical mitral valves in it, and that's where they showed that patients with mechanical mitral valves and rheumatic mitral stenosis and AFib did worse. So since that trial came out first, then these other trials excluded them from their study. So that's why we actually don't use novel anticoagulants with patients with valvular AFib anymore, right? So this did have some valvular AFib, but these trials did not have. But they still had severe valvular heart disease patients in them. So hemodynamically significant valve disease was only excluded from Rocket AF and Rely. And then if you look at bioprosthetic valves were not excluded from all the trials. Mechanical valves were excluded from all the trials, but bioprosthetic valves were not excluded from all the trials. So based on that population of the patients that they included, then we can tease out some information about what is the efficacy of these anticoagulants, the newer anticoagulants, in patients with several of these different conditions. So if you look at it, about 26% of patients in Aristotle, 21 and 14 and the other trials had at least moderate valvular heart disease patients. Several of them, 19, 17, and 89% had mitral regurgitation. So there's a huge percentage of patients in Rocket AF trial that had mitral regurgitation. So these are patients that we typically think are valvular AFib patients, right, in the past. and that is probably why ACC/AHA this year in 2016 excluded mitral regurgitation from the definition of valvular AFib, because these patients actually still did well. And then, mitral stenosis, they still had a little bit of mild mitral stenosis patients in these trials, and there were several aortic regurgitation, aortic stenosis, tricuspid regurgitation in these patients. These ones we usually don't worry about, but I'm just showing you there were still a whole bunch of valvular heart disease patients, not valvular AFib patients that were in the trial. So if you look at those patients, so what was the efficacy of the drug compared to Coumadin in patients with valvular heart disease compared to patients without valvular heart disease for systemic thromboembolism, for major bleed or mortality, was pretty much the same as Coumadin. So it prevented the same amount of thromboembolic events and strokes. It did not cause so much more bleeding, and the mortality was about the same between valvular heart disease patients and non-valvular heart disease patients in both the arms, in Coumadin and the novel anticoagulant arm. So therefore, just because a patient has severe mitral regurgitation or severe aortic stenosis or severe aortic regurgitation, you don't have to stop using these novel anticoagulants in patients who have AFib. Is that clear? Okay. All right. So how about bioprosthetic valves? This is the argument that we had during one of these months, actually in the heart failure in the cardiology service, is whether you can use novel anticoagulants in patients who have bioprosthetic valves. Unfortunately, the data is not very clear in the bioprosthetic valve area. So this is a subgroup analysis of the Aristotle trial where Apixiban was compared to warfarin. There were about 40 some odd patients, 41 patients in the Apixiban arm and 41 patients in the Coumadin arm that had bioprosthetic mitral valves in place. And so as you see here, their outcomes were not different from patients who had who were on Coumadin. For major bleeding, stroke, or all-cause mortality, even cardiovascular mortality, it wasn't different. So based on this one study, maybe you can still use novel anticoagulants, especially Apixiban, Eliquis, because that data is pretty clear. This is a prospective randomized control trial that was done with dabigatran. Unfortunately, there were supposed to be 50 patients in this arm and 50 patients in this arm. They only recruited about 15 in this arm and 12 in this arm. They did not complete the study, but they still went ahead and published the data that shows that there is, again, no difference in patients who have bioprosthetic mitral valves, and they got dabigatran for thromboembolic prevention in AFib patients. Sorry, this is a little bit more complicated slide. I just want to go over this with you. This is a very recently published trial about a month ago. This is a subgroup analysis of Aristotle, not Aristotle, sorry, Engage AF trial that looked at Edoxaban. And they've separated their groups into patients who had bioprosthetic valves, and then they separated the ones that got Edoxaban into high-dose Edoxaban and low-dose Edoxaban. So if you look at it both for stroke prophylaxis, which is this graph here, major bleeding, which is this graph here, and minor bleeding, which is this graph here. The red line is the number of events in patients who are on Coumadin. The green line is patients who were on low-dose Edoxaban, and blue line is patients who were on high-dose Edoxaban. So if you look at it, warfarin patients had more events, whether it's major bleeding, minor bleeding, or thromboembolic strokes, compared to both low-dose and high-dose Edoxaban. So if you take all these data into consideration, maybe you can still use bioprosthetic, you can use novel anticoagulants, at least Apixiban and Edoxaban in patients who have bioprosthetic heart valves and they have AFib, okay? So this would not be asked in your boards, but it might come up in your practice. Boards, they won't ask you anything that is controversial, so you will probably never see a question on bioprosthetic heart valves and NOACs, but in your practice, it's really up to you if you want to do one way or the other. So final word, mitral stenosis without prior, this is what I think most of you guys actually made a mistake here. You said 2.5 to 3.5. 2.5 to 3.5 is only in patients who have a valvular AFib and a prior history of stroke. If they did not have a prior history of stroke, it's the same warfarin INR range that you usually follow for all AFib patients, which is 2 to 3. Okay? And then, especially with these newer valves that come out that do not require you to have higher anticoagulation range. Okay? So I'm not talking about the old, really old valves, the newer valves that don't require higher anticoagulation. You can just stick with 2 to 3. So if you require it for the valve, if you require 2.5 to 3.5 range for the valve, then you go with that, that number. But for AFib alone, you can just go with 2 to 3. For MR, there is no specific recommendations. As I told you before, you can go with NOVAX for patients with AFib and MR. And mechanical valves, the INR range is 2 in the aortic position if you use one of those newer valves. But in the older valves, again, you stick with the recommendations for the valve and not for AFib. And then 2.5 in the mitral position, dabigatran should not be used. And in 2014 update, they clearly said NOAC should not be used for mechanical aortic valve. Bioprosthetic aortic valve, not a board question, but for your practice, I think you can use based on upcoming data. At least Edoxaban and Apixaban can be used based on some of the subgroup analysis. All right. So then this patient who came in for an AFib ablation, what do we do? Do we do an AFib ablation? How good is AFib ablation for patients who have a mechanical valve? Before I go on to the mechanical valve, I just wanted to show you some data about what is the data on AFib ablation in any patients who have severe valvular heart disease and AFib. So if you look at it, this is actually a study that was done by Andrea Natale, who's actually one of the kings of AFib ablation in Cleveland Clinic. This had about 391 patients separated out into lone atrial fibrillation, patients with atrial fibrillation and a significant valvular heart disease, and then patients who had atrial fibrillation and had any other cardiovascular surgery done. And so if you look at it, the only things that were different, actually that is not in this graph, but this group of patients, the patients with valvular heart disease and significant AFib, had more advanced NYHA class, and they were older, and they had larger left atrial diameters. But otherwise, they were all pretty much significant. So if anything, this group was a little bit more sicker AFib group compared to the other patients. And if you look at the recurrence rate after an AFib ablation, there was a slightly higher trend in valvular heart disease patients, but was not statistically significant. So you can still go ahead and ablate patients who have valvular heart disease, even if they have significant valvular disease. You have a question? Right. So, and then when we do AFib ablations, this is a graph that shows persistent atrial fibrillation patients. I'm sorry I'm going into some of the details of AFib ablation, but just in case you come across a patient that has had an AFib ablation done in the past. So when we do AFib ablation, what we do is we first isolate the pulmonary veins. That is the main focus of the procedure, is just isolating the pulmonary veins, which is burning up around the pulmonary veins. Once that's done, if the patient is still not in sinus rhythm, then we do what is called cafe ablations, which is complex fractionated atrial electrograms. We go check in the atria for where are the places that have really fractionated electrograms, and wherever there are fractionated electrograms, we burn them. And if we still don't have sinus rhythm, then we go ahead and shock these patients. So this is a study where they took 111 cases. About 60 of them were normal controls where they did not have significant valvular disease. 51 of them had significant valvular disease. So then they saw how many of these patients converted back to sinus rhythm with just doing a PVI, which is pulmonary vein isolation. So about 3 patients in this group with valvular heart disease converted to sinus rhythm, and 9 of them converted to sinus rhythm in the group that did not have valvular heart disease. And then did cafe ablations, again 3 more, so total of 6 converted to sinus rhythm, and here about 12, 3 more here, about 12 of them converted to sinus rhythm. All the rest had to be cardioverted to bring them back into sinus rhythm. Once they were back in sinus rhythm, these patients were followed up for 1 year, and you can see there is no significant difference in the recurrence rates of atrial fibrillation after you put them back into sinus rhythm. So this again shows that if you had severe valvular heart disease and AFib, you can still go ahead and ablate these patients. The only problem is, the one that is not shown in this graph, is the fluoroscopy time when you do AFib ablation in these patients are much higher compared to non-valvular AFib patients. I'm going to skip this one. I'm going to show you this. Now, you have a lot of patients that come into your service, medicine service, either with severe valvular heart disease or infective endocarditis, something where you refer these patients to the cardiothoracic surgeons to have a surgery done, open heart surgery, whether it's valve replacement or bypass surgery done, right? So these patients might have coexistent AFib with these heart conditions. So how many of you tell the surgeon, hey, I want a MACE procedure done when you do the surgery? The surgeons are supposed to do what you guys ask them to do, technically at least, right? So how many of you know what a MACE procedure is? Oh, not many. So MACE procedure is basically like doing a pulmonary vein isolation, and we call linear lines. So it's like doing that, except instead of burning, what the surgeon does is when he opens the heart, he goes inside with a kind of a rod-looking thing that either you can freeze it or they can use radio frequency and heat. They do the same exact things, but inside the heart when they have the heart open. In the past, typical MACE procedure used to be they used to actually incise the heart and resuture it in that same pattern, which causes fibrosis and then causes exit blocks from the pulmonary veins. Nowadays, we don't do that anymore. Already, the surgeons don't even do what we ask them to do. So in the current day and era, what we do is we just use these rods and they either freeze them or they heat them up, and they cause burns inside the heart in a pattern that causes exit blocks from these pulmonary veins and isolates these pulmonary veins. So this particular study looked at a specific question. When you send these patients with a mechanical mitral valve or bioprosthetic mitral valve, so these are all patients that had valvular heart disease to begin with, and they had AFib as well, and they're all going for surgery. Now, do you tell the surgeons to do a MACE procedure, or after the surgery you bring them back for an AFib ablation internally like how we usually do? So these are both Chinese studies that were done about 3 years apart. This was published, I think, in 2010, and this was in 2013. About the same number of patients, 90 patients each, 45 patients in each arm. In one group, what they did was in the group A, in this one, the lower line here, this one, the lower line here, they did the surgery first, and then 6 months later, they brought the patient in for an AFib ablation internally like how we usually do. The other group, they asked the surgeon to do the MACE procedure. So if you look at it, the patients who did not have much AFib recurrence are patients who had the MACE procedure done during the surgery. Okay? Both the studies clearly show that if you have a patient with a valvular heart disease and have AFib, you're better off to ask the surgeon to do the MACE procedure during the surgery than to bring the patient later on for an AFib ablation. Okay? Is that clear? So you guys are going to start asking your surgeons to do the MACE procedure from now on, right? All right. So then, patients with mechanical mitral valves, when you go inside and do an ablation, like how we usually do a radio frequency ablation, how do these patients fare? So if you look at it, the AFib recurrence is, the p-value is 1, which means exactly the same recurrence rate in patients who had a mechanical mitral valve prosthesis and control subjects. So no difference. But if you look at the other parameters, fluoroscopy time was much higher. There were a little bit more complications. Most of these complications were either groin complications. There was one TIA, and then there was one esophageal burn. But otherwise, they didn't actually hurt the valve much. What is the biggest problem you think in going inside the heart with a catheter to ablate AFib in these patients who have mechanical mitral valve? Somebody told me before that it was a complicated procedure. I'm wondering who it was. You did. So Munish, why do you think it's so complicated?
It's already fibrous and it's close to the AV node.
It's not close to the AV node, but I'll show you why. Okay, so when we isolate the pulmonary veins, we actually put in a catheter inside the pulmonary vein. This is called a lasso catheter, which you can see it's like a loop, and this is called a pentaray catheter, which has 5 prongs to it. Either one of these, we have to put it inside the pulmonary vein, and then when we encircle the pulmonary vein with burns, then we can see the pulmonary veins go quiet, which means that we've isolated the pulmonary veins. So imagine one of these things getting caught in the mechanical mitral valve. Okay? So it's very easy to say, oh, you can operate without getting these caught in the mitral valve. Well, I'll tell you, sometimes you clock the catheter to get the lasso catheter move from one place to another, and it gets caught on something, it won't move, and all the torque will build up, and suddenly the catheter jumps from the pulmonary vein straight into the mitral valve. Okay? If you do that and you try to pull, this is what happens. So this patient actually had this small piece take off and go elsewhere into the systemic circulation and die from it. Okay? So that is why it's so complicated to do afibrillations in patients who have mechanical mitral valve. Actually, if this is bad, this is even worse. If this gets caught, this even can get caught in the normal mitral valve apparatus, and when you try to pull it out, you can actually tear the mitral valve apparatus. So you have to be really careful, and that's why it's so complicated to do these procedures. So these guys actually looked at 4 different studies. They did a systematic review to look at what are the outcomes of patients who have mechanical mitral valves that go on for an AFib ablation. And this is the one study that I showed you before that didn't show much of a difference, but there are 3 other studies with quite a bit of patients, about 178 patients in this arm and about 285 patients in the control arm. And if you look at it, so this is mechanical mitral valve patients, these are control patients, and this graph shows procedural time, this graph shows fluoro time, and both, so these are 3 different studies. This is Lang et al., Lockheed et al., and Hussain, and this is the summary data, the red bars here and here and here. So if you can see, the procedural times are much higher in patients who have mechanical mitral valves compared to normal controls. The fluoroscopy time is much higher because all the time, we usually ablate by just using a 3-dimensional map of the atrium. We actually do not look at fluoroscopy. But when you have a mechanical mitral valve, you want to fluoro every once in a while to make sure your catheter is not even close to the mechanical mitral valve. So you are going to have a lot of fluoroscopy time. And then when you look at the outcomes, these patients who have a mechanical mitral valve actually have a higher recurrence rate. In this case, 36% recurred back in AFib compared to 26% who did not have a mechanical mitral valve and had higher complication rate as well. So, it's a bargain. If you can do a MACE procedure when they are having a valve surgery done, it's better. If they did not have it done and they're extremely symptomatic like our patient, you can still go ahead and do it, but make sure the patient understands the risk of doing it. And number 2, the success rate is not as good as patients who don't have a mechanical mitral valve. So I'm going to skip this in the interest of time. And this is our patient, so we went ahead and did a mechanical AFib ablation in this patient. And so we actually ablated the left superior and inferior pulmonary veins. All these red marks that you're seeing are ablation dots. And this is the right-sided pulmonary veins. We got all of it except a small portion of the right inferior pulmonary vein, which we could not ablate because this gray structure here, as we call as the gray goose, is the esophagus. So the esophagus was super close to the left atrium that every time we burnt there, the temperature rose up and there was a higher risk of atrioesophageal fistula, which is more dangerous than having AFib. So we decided not to completely isolate that one vein, but all the other 3 veins are there, and she's doing very well. All right. So going on to the next topic, which is heart blocks and valvular heart disease. How many of you here are familiar with the structure of the AV node and the valves and all those things? All right. So this is a very complicated anatomy picture, but this is inside the heart. This, kind of a very irregular structure that you're seeing is the right ventricle. This is the aortic, the tricuspid valve. You're basically cutting the tricuspid valve right in the middle like that. So the tricuspid valve goes in a circle like that. and then the RV goes like that. And this is the atrium here. So this is the annulus of the tricuspid valve. This is the coronary sinus, which is the vein that drains blood back from the rest of the heart back into the right atrium. And here is the what we call as the tendon of Todaro. And the membranous septum is right at the apex of that triangle. And that's where the compact AV node sits. So if you look at the compact AV node, it sits right in the junction of the septum and the aortic valve, the septum and the mitral valve, and the septum and the tricuspid valve. So any of these three valves, except the pulmonic valve, if you interfere with any of the valves, you can actually obstruct or you can cause damage to the AV node and cause a heart block. Okay. So here is two different studies. One was a prospective study with about 260 patients here, and this was a retrospective study with about 1,100 patients here. These had all kinds of valve surgeries. This had only aortic valve replacement done. In this study, about 3.2% of patients developed complete heart block, and in this one, about 17% developed some kind of heart block where they required at least a temporary pacing, and as much as 7% of them ended up requiring a full permanent pacemaker put in after their valve surgery is done. So it's important for you to recognize that one of the complications of even the best aortic valve surgery or the best valvular surgery, whether it is the tricuspid valve, the aortic valve, or the mitral valve, except the pulmonic valve, any valve surgeries can cause complete heart block. And when they looked at what are the factors that causes more heart blocks in these patients, any patients with aortic regurgitation had more blocks, any patient who had a prior MI had more blocks, anybody who had a pulmonary hypertension or postoperative electrolyte imbalance had more incidence of complete AV nodal block when they had aortic valve replacement surgery done. And in this case, the things that were significant was actually the length of hospitalization was more of an effect than a cause. But if you look at bioprosthetic valves, they cause more heart blocks than mechanical valves. Anybody who was on a beta blocker or an antiarrhythmic agent had more heart blocks. All right, so here is another study, but this is looking at only mitral valves. The one I showed you before, this one is only aortic valves. This is all combination. And this one is only aortic valves. In this one, about 391 patients went on to have a mitral valve replacement surgery done. About 70 of those patients, about 17%, developed type 1 AV block, and about 22% of them developed either a type 2 heart block or a type 3 heart block, both of which requires a pacemaker put in. And if you look at, again, what are the prognostic factors for having a heart block when you have a mitral valve surgery done, anybody who was on digoxin, amiodarone, or sotalol, or if their cross-clamp time was much higher, these patients actually ended up developing more heart blocks in their postoperative course. Again, this is another study looking at post-aortic valve replacement surgery heart blocks. There were about 2,000 odd patients in this study. About 6.6% of them required pacemaker put in. Now, I wanted to show you what are the indications for the pacemakers in these patients. Most of them, 75% of them got a pacemaker because they developed a complete heart block, like I talked about before, because of the proximity of the AV node, the compact AV node, to the aortic valve. But some of them, about 16% of them got a pacemaker also for slow AFib. About 6% of them got for a slow rate, probably a sinus arrest with a white complex escape. And then sinus node dysfunction about 2% and asystole about 1%. And most of these patients actually ended up getting the pacemaker either perioperatively during the surgery or just after the surgery from postoperative day 3 to 7. And then they followed these patients for a very long period of time and saw how many of these patients still ended up using these pacemakers. You would be surprised to see the number of patients who get a pacemaker for 1,000 odd reasons, and then you follow them. These patients will end up in our clinic. They had their pacemakers put in XYZ hospital in XYZ city, but they come here for follow-up, and we see they never use their pacemaker. Okay, and that happens because there is a temporary phenomena that causes heart blocks or sinus node dysfunction for which they get the pacemaker, but they never end up using it in the long run. So if you look at it, these patients, most of them did end up using their pacemakers even after a very long period of time. About 68 of them, of the ones that were followed up, so there were a total of about 80 something followed up, around 68% of them still were dependent on these pacemakers, which means these heart blocks that develop after an aortic valve replacement surgery are significant and are permanent damage that you have to keep in mind. So what about the new procedure, that transcatheter aortic valve replacement surgeries, TAVR patients? How many of these patients end up developing heart block, you think? More or less than the open valve surgery patients? Huh? You say less? Actually not. So more of these patients end up developing heart block because of multiple reasons. One is the catheter manipulation of things in that area. Usually when we do EP studies, for example, we put in catheters into the right and the left atrium and the left ventricle, and many of the fellows, if they don't know what they are doing, they might push the catheter a little bit further into the right ventricle, and you will see a right bundle branch block instantaneously. Because the right bundle is actually very superficial, you can just hurt it with just a movement of the catheter. If that is the case, imagine all the pressure that they put in the aortic valve area when they are doing these transcatheter aortic valve replacement surgery. They actually have to blow up the balloon and mash up the tissue to hold the valve up. So they actually cause more heart blocks than the open heart surgeries. The other reason why they cause more heart blocks is because when you have an open surgery, you can match the size of the valve to the size of the valve opening very well, the left ventricular outflow tract. In many cases, when you actually have a TAVR procedure, you're not actually seeing the valve. You're relying on some kind of an imaging technique, which includes a transesophageal echocardiogram or a CT scan of the chest, and that's what you base your size of the valve on. So you actually end up using a much bigger valve for a smaller size, and then you end up having more heart blocks. These are the patients who did not develop heart block. These are all patients who had surgery, and then these are the patients who developed new onset heart block, complete heart block that they had during a TAVR procedure. So if you look at it, what are the prognostic factors that you can, prior to surgery say, okay, these are factors if your patients have, you have to be more careful because they can develop a complete heart block. The most important thing you keep in mind is right bundle branch block. Where do you think that is? The right is already gone, exactly. So because the right is already gone, your left is the one that gets injured the most during a transcatheter aortic valve replacement. And so now you have a complete heart block. If you did have a functioning right bundle, then once you hurt the left bundle, you at least survive with the left bundle branch block. You don't require a complete heart block. So that is the theory behind the postoperative, preoperative right bundle branch block patients. And then if you had an intraoperative block, when you have the surgery, when you're actually in the process of putting in the valve, you develop a heart block, those patients end up needing a permanent pacemaker and having a permanent pacemaker put in the long run, compared to patients who develop a heart block within the next few days. What do you think that is? Everything has a logic, right? Think.
Is it inflammation?
Good. It's inflammation and edema. The ones that actually develop a heart block within the next couple of days, 3, 4, 5 days, those patients, after the valve was put in, they develop an edema that causes, pressure on the AV node that blocks the function of the AV node, and that'll go away after a while. Now, if you actually went inside, blew up a balloon, you saw a heart block right away, that is probably direct injury to the AV node. That's not going to go away. So if you had an intraoperative block, then those patients are going to require a permanent pacemaker. Core valve, this is the kind of valve, Medtronic core valve is the biggest used valve for transcatheter aortic valve replacement surgeries right now. And that is the one valve that causes the most complete heart blocks. Okay? And there's other ones called Edwards Sapien, but this is the most common one that we use, and that's the most common one that gives me a lot of business. Unfortunately, we don't do TAVRs here, so I don't get a lot of business from this. And so balloon valvuloplasty, if you actually, as I told you before, if you mismatch the size of the valve to the size of the LVOT, the left ventricular outflow tract, or the opening of where the valve has to sit, you have a more injury. When they did a multivariate analysis, the only thing that actually went was clearly significant was the intraoperative AV block. The rest of them did not turn out to be significant in multivariate analysis. So again, I just wanted to reiterate the fact that if you have a pre-existent right bundle branch block, and if you actually mismatch the size of your the prosthetic valve to the size of your LVOT, you're prone to get a post-TAVR heart block. So here is the pacemaker implants after TAVR. If you see, most of the pacemakers are implanted within the first 0, 1, and 2 days, and then the rest of them are later. And most of them are due to AV block. The big blue circle here is all AV block patients. There's a small proportion of patients here due to sinus node dysfunction, most probably because these are older patients who go on to have these surgeries done. It's just purely coincidental that these patients have sinus bradycardia during the surgery, and the surgeons and the cardiologists freak out and they ask for a pacemaker put in, and we put in a pacemaker. And most of these patients end up with a dual chamber pacemaker, but there is a small number of them that end up with a single chamber or an ICD or a bi-V ICD put in. So here is one data I wanted to show you. So if you did get a pacemaker put in after a TAVR placement, so you had a TAVR, you had a pacemaker put in, so what is the big deal? So you're going to live with the pacemaker, so what? Well, it's not so clear if that's all the impact is. So if you look at patients who got a pacemaker compared to who did not get a pacemaker, so the red line is patients who got a new pacemaker put in after a TAVR placement compared to the blue line who did not have pacemakers put in. These patients actually have a higher mortality. There is a slight decline in EF, but it is not statistically significant. So there could be other, and their hospitalization rates are also, the duration of hospitalization is also higher when they get a pacemaker put in. It's about 2.8 days more for patients who get a pacemaker compared to patients who do not get a pacemaker. And the repeat hospitalization rates are also higher in patients who get a pacemaker put in after a TAVR, about 24% compared to 18% who don't have it. But there was a meta-analysis done of not only this study that I showed you, which is actually Nassif et al. Here, but there were multiple other studies. And the meta-analysis does not show that there is an increased mortality rate when you get a pacemaker put in. But this meta-analysis went on to show that instead of a complete heart block, you just developed a left bundle branch block. Those patients actually ended up having worse prognosis. Their all-cause death was higher, and I am not sure if this is cardiovascular mortality, but that is higher as well. So maybe, complete heart block is and requiring a pacemaker is not as bad as just developing a left bundle branch block, which tells me that maybe some of these patients who develop a left bundle branch block in the hospital will go on as an outpatient to develop a complete heart block where they are not noticed, and they might die as an outpatient before they can be notified. So here is a small diagram for the use of people. We don't do as many TAVRs here, but if you go on to a center that does a TAVR and you get a consult for a heart block after a TAVR, this is the algorithm that you can follow. So if your pre-procedure ECG shows right bundle branch block, a left anterior fascicular block, or a first degree AV block, you have a higher rate of developing a complete heart block, so pay closer attention to these patients. And if your peri-procedure ECG shows no change, then you can take the temporary pacemaker out, which every patient gets during the TAVR procedure, in about 24 to 48 hours. If you do see a first degree heart block after the surgery, then you monitor them for another 24 to 48 hours. There is nothing, then you send them home, but on a Holter monitor. Now, if you develop a new left bundle branch block or a second degree AV block, you monitor them really closely and you keep the pacemaker, the temporary pacemaker, for a little longer. Remember, these patients are the ones that have a worse prognosis. They actually can go home and die from a complete heart block, whereas what you just saw in the hospital was just the beginning of the complete heart block. You saw a left bundle branch block, and then they further develop a complete heart block when they go home. So you monitor these patients closely, and when you send them home on a 30-day event monitor or implantable loop recorder. And these patients are cleared, Mobitz type 2 AV block and third degree AV block. You just go ahead and put a complete permanent pacemaker right in the hospital before they get discharged. So I think that's all I have. So the summary, if you have a patient with moderate to severe mitral stenosis, a bioprosthetic valve anywhere in your heart, or you have a mechanical valve, or you have a mitral valve repair, those are, if those patients have AFib, those patients have what we call as valvular AFib, where you cannot use novel anticoagulants except for bioprosthetic valves, where it's still debatable. But all other patients, you stick with Coumadin, and you dose the Coumadin for an INR of 2 to 3 if they have a newer valve, or 2.5 to 3.5 if they have an older valve, or they have a prior history of stroke. Patients who have mitral valve disease and aortic valve disease do as well as the other patients when it comes to AFib ablations, but when they have a bioprosthetic valve, their outcomes may not be as good. So if you're actually referring a patient for a valve surgery, it's important for you to ask the surgeon to do a MACE procedure. They already had a pre-existing history of AFib. And then we talked about the heart blocks after valve surgeries. All valve surgeries except pulmonic valve surgeries have a higher incidence of complete heart block after valve surgery, so please pay close attention to it. And TAVR patients actually have a slightly higher incidence of heart blocks, and if they had a pre-existing right bundle branch block or a first-degree AV block or in the left anterior fascicular block, these patients actually have even more higher incidence of complete heart block after valve surgery. So those are two main arrhythmias that we talked about today, AFib and then heart blocks in valve patients. Any questions? Wow, so hard. All right, thank you.